Unit 23. Cancer chemotherapy. Indubitibus et ignorantibus spice cancer. Learning objectives. After completing this unit, the students should be able to 1. Describe various types of cancer and the mechanisms involved in the development of cancerous tumors. 2. Understand the terminology related to contemporary cancer chemotherapy, including the different drugs, their mechanisms of action, and side effects. 3. Engage in collaborative discussions using terminology. 4. Demonstrate an ability to use rhetorical functions needed to write a letter to a colleague. 5. Describe schemes and graphs using academic vocabulary and appropriate terminology. 6. Use word-building skills to enrich the vocabulary. 7. Summarize scientific articles using appropriate academic words and phrases. Text 1. Read the text and do the exercises, then retell the text using information provided in exercise 1.2. Drugs used in cancer chemotherapy. Of the drugs in this group, cyclophosphamide is commonly used to treat chronic lymphocytic leukemia, lymphoma, and ovarian and testicular cancers. Cyclophosphamide produces severe nausea and is often used with a 5-HT3 antagonist, ondansetron. Cyclophosphamide is metabolized to a toxic metabolite called acrolein, which can cause hemorrhagic cystitis, a rare but serious complication. This effect can be counteracted by a high intake of fluid and by using a drug called mesna. Otherwise, cyclophosphamide can cause bone marrow depression, sterility, and increased risk of other cancers. There are many drugs in this group of anti-cancer drugs. Some other examples are busulfan, for leukemia, carmustine, for brain tumors, treosulfan, for ovarian cancer, and cisplatin, for lung, testicular, bladder, ovarian and cervical cancers. Antimetabolites block or alter a metabolic pathway involved in DNA synthesis. They are analogues or antagonists of normal cell constituents. Methotrexate is a folate antagonist that competes for an enzyme, dihydrofolate reductase, necessary for the conversion of folate into its active form. The active form of folate is a cofactor needed for the synthesis of nucleotides adenine and guanine, which form part of DNA and RNA. In this way, protein synthesis and cell division are interfered with. Methotrexate is also used to treat rheumatoid arthritis and severe psoriasis. Resistance to methotrexate occurs possibly due to reduced uptake into cancer cells or altered enzyme activity. Adverse effects of methotrexate include ulceration of the mouth and lower gastrointestinal tract and bone marrow suppression. With high doses of methotrexate, synthetic folinates are used to prevent irreversible bone marrow damage. Mercaptopurine is a purine analog that substitutes for purine bases, adenine and guanine, in the synthesis of DNA. It is converted to a false nucleotide that inhibits the formation of normal DNA. Adverse effects of mercaptopurine are similar to methotrexate. Mercaptopurine is metabolized by xanthine oxidase. It should be used with caution in combination with allopurinol because allopurinol inhibits xanthine oxidase. Both methotrexate and mercaptopurine are used to treat acute leukemia. Fluorouracil is a pyrimidine analog that substitutes for uracil in the synthesis pathway for thymidylate, a necessary step in the synthesis of DNA. Formation of a false nucleotide inhibits an enzyme necessary for DNA synthesis. This is similar to the mode of action of the antifungal drug, flucytosine. Fluorouracil is used to treat gastrointestinal and breast cancers, often together with synthetic folinates. Adverse effects of fluorouracil are less likely, but similar to methotrexate. Cytarabine is a pyrimidine analog, which is incorporated into both RNA and DNA and interferes with the action of DNA polymerase. Cytarabine is used to treat leukemia. Adverse effects of cytarabine are bone marrow suppression and gastrointestinal disturbances. Some cytotoxic antibiotics prevent cell division by direct action on DNA. Others form polynucleotides, which inhibit transcription of DNA to RNA and therefore suppress protein synthesis. Examples of cytotoxic antibiotics are doxorubicin, dactinomycin, and bleomycin. Doxorubicin inhibits an enzyme called topoisomerase, also known as DNA gyrase. During replication of DNA, this enzyme brings about swiveling of individual strands of DNA so they can be copied without becoming entangled in each other. Doxorubicin prevents this. Doxorubicin is used to treat leukemia, lymphoma, and many solid tumors. Apart from nausea and vomiting and bone marrow suppression, adverse effects with doxorubicin are cardiotoxicity and possibility of cardiac failure. Dactinomycin binds to guanine in DNA and prevents the movement of RNA polymerase, so interfering with protein synthesis. Dactinomycin is mainly used to treat cancers in children. Adverse effects are bone marrow suppression and nausea and vomiting. Bleomycin degrades DNA to cause fragmentation of the strands. Bleomycin is most effective in the G2 phase and during mitosis of the cell cycle, but it is also effective against cells in the Go phase. Bleomycin is used to treat squamous cell carcinoma. Bleomycin is unusual among cytotoxic drugs in that it does not cause bone marrow suppression. However, it is associated with blistering skin rashes and serious progressive pulmonary fibrosis in 10% of patients. Text 3. Read the text and analyze the recent advancements in targeted therapies. Discuss the potential implications for personalized medicine and therapeutic optimization. Write down the main arguments made in the text, emphasizing their significance. Blood test could enable early detection of cancer in people with neurofibromatosis type 1. People with an inherited condition known as neurofibromatosis type 1, or NF1, often develop non-cancerous, or benign, tumors that grow along nerves. These tumors can sometimes turn into aggressive cancers, but there hasn't been a good way to determine whether this transformation to cancer has happened. Researchers from the National Cancer Institute's, NCI, Center for Cancer Research, part of the National Institutes of Health, and Washington University School of Medicine in St. Louis have developed a blood test that, they believe, could one day offer a highly sensitive and inexpensive approach to detect cancer early in people with NF1. The blood test could also help doctors monitor how well patients are responding to treatment for their cancer. NF1 is the most common cancer predisposition syndrome, affecting 1 in 3,000 people worldwide. The condition, caused by a mutation in a gene called NF1, is almost always diagnosed in childhood. Roughly half of people with NF1 will develop large, but benign tumors on nerves, called plexiform neurofibromas. In up to 15% of people with plexiform neurofibromas, these benign tumors turn into an aggressive form of cancer known as malignant peripheral nerve sheath tumor, or MPNST. Patients with MPNST have a poor prognosis because the cancer can quickly spread and often becomes resistant to both chemotherapy and radiation. Among people diagnosed with MPNST, 80% die within 5 years. Imagine going through life with a cancer predisposition syndrome like NF1. It's kind of like a ticking bomb, said study co-author Jack F. Chern, MD, Alaska clinical research scholar in NCI's pediatric oncology branch. The doctors are going to be watching for cancerous tumors, and you're going to be watching for them, but you really want to discover that transformation to cancer as early as possible. Doctors currently use either imaging scans, MRI or PET scan, or biopsies to determine if plexiform neurofibromas have transformed into MPNST. However, biopsy findings aren't always accurate and the procedure can be extremely painful for patients because the tumors grow along nerves. Imaging tests, meanwhile, are expensive and can also be inaccurate. Dr. Schön and his collaborators of Washington University School of Medicine collected blood samples from 23 people with plexiform neurofibromas, 14 patients with MPNST that had not yet been treated, and 16 healthy people without NF1. Most of the study participants were adolescents and young adults, the age group in which MPNST most often develops. The researchers isolated cell-free DNA, that is, DNA shed from cells, into the blood from the blood samples, and used whole genome sequencing technology to look for differences in the genetic material among the three groups. The cell-free DNA in patients with MPNST had several features that distinguished it from the DNA in the other two groups. For example, patients with MPNST, you can imagine treating a patient with a chemotherapy regimen. This blood test could easily and rapidly allow us to determine whether the disease is going down or maybe even going away entirely, Dr. Schön said. And if you had done surgery and taken out an MPNST, and the blood test was negative, you could use that to monitor the patient going forward to see if the tumor returns. Dr. Schön noted that one limitation of the current study is its small size, even though it included people with NF1 from two large hospitals. The researchers are planning to conduct a larger trial with more patients. Dr. Schön said the team's goal is to increase the accuracy of the blood test from 86% to closer to 100%. One approach would be to refine the genetic analysis to focus on genes known to be involved in MPNST. A simple and inexpensive blood test to detect MPNST early in NF1 patients would be especially useful in developing countries and other resource-poor areas, where access to the equipment and expertise needed to perform imaging is limited, Dr. Schön said. Blood tests of this type also have applications in the early detection and monitoring of patients with other cancer-predisposing genetic disorders, such as multiple endocrine neoplasia, in which benign tumors can turn cancerous, or Li-Fraumeni syndrome, which increases one's risk for developing several types of cancer. This is the perfect opportunity to apply these technologies, where we can use a simple blood test to screen an at-risk population, said Dr. Schön. If the test shows something abnormal, that's when we know to act and go looking for a tumor. Exercise 3.1. Answer the following questions. 1. What kind of test has the NCI developed? 2. What do you know about NF1? 3. What is MPNST? Why does it have a poor prognosis? 4. What procedures are used to diagnose MPNST? Are they accurate? 5. What kind of research did Dr. Schön and his colleagues conduct? 6. How did the researchers differentiate patients with plexiform neurofibromas and MPNST? 7. What result indicates metastatic recurrence? 8. What is the goal of the team? 9. What are the potential applications of the new blood test? Exercise 3.2. Test your comprehension through a set of multiple-choice questions. Each question is designed to assess your understanding of key concepts and their application. Choose the option that you believe provides the most accurate response based on your knowledge and critical thinking. 1. Which of the following is not a neurodegenerative disorder? A. Neurofibromatosis. B. Alzheimer's disease. C. Huntington's disease. D. All of the above are neurodegenerative disorders. 2. When beta-amyloid aggregates into oligomers and forms diffuse and neuritic plaques in the blood vessels, it is called A. Amyloid neuropathy. B. Amyloid angiopathy. C. Amyloid encephalopathy. D. Amyloid clotting. 3. Beta-amyloid oligomers and plaques do all of the following except A. Block proteasome function. B. Inhibit mitochondrial activity. C. Alter intracellular Ca2+ levels. D. Inhibit inflammatory processes. 4. What is the name of enzyme that phosphorylates the tau proteins? A. Bradykinin B, tau hydroxylase C, protein kinase D, tau phosphorylase. 5. Neurofibromatosis is an autosomal recessive disorder. A. True B, false. 6. The hallmark of is the presence of at least 6 café au lait spots. A. NF1B, NF2. 7. Optic nerve gliomas and Lisch nodules are commonly seen with neurofibromatosis. A. Type 1, Lisch nodules equals pigmented nodules of the iris. B. Type 2C, Type 1 and 2. 8. Neurofibromas and neurofibrosarcomas are often seen in neurofibromatosis A. Type 1B, Type 2. 9. NF type 2 is characterized by the development of non-cancerous tumors called on the nerves that control hearing and balance. A. Gliomas B, schwannomas C, auditoromas D, neurofibromas. 10. A normal NF1 gene is a tumor suppressor gene, and loss of tumor suppression in NF1 mutations allows to form. A. Neurofibromas. This gene is located on chromosome 17 and encodes for neurofibromin. B. Schwannomas C, fibrin D, meningiomas. 11. Merlin is a tumor suppressor gene, and mutation leads to the formation of A. Neurofibromas B, pseudonthostomas C, gliomas D, schwannomas. Text 4. Read the publication on a new therapeutic agent, then assess the study design and results. Critically evaluate the strength of the evidence presented and discuss the implications for clinical practice and patient care. Summarize the main points of the text in your own words in writing. Virotherapy for brain tumors, defining the path to success. Most high-grade gliomas are associated with dismal survival in both adults and children, even after aggressive treatment. Despite initial promise, immunotherapy with immune checkpoint inhibitors or peptide vaccines has failed to show efficacy in Phase 3, randomized trials involving patients with glioblastoma, the most common World Health Organization grade 4 glioma in adults. The lack of progress in developing effective immunotherapies for adult and pediatric high-grade glioma can be explained by several factors, including scarcity of tumor-infiltrating lymphocytes, T-cell exhaustion, low somatic mutational load with decreased burden of tumor-specific antigens, and systemic immunosuppression, both tumor and treatment-induced. In the past several years, work on oncolytic viruses, as an alternative treatment of cancer, has been gaining momentum. In 2015, Talimogene lahaparapvec, a genetically modified herpes simplex virus type 1, HSV1, received regulatory approval by the Food and Drug Administration and the European Medicines Agency for the treatment of recurrent melanoma. Although the initial rationale behind the use of engineered, conditionally replicating viruses in the treatment of cancer has been their ability to replicate and kill tumor cells, preclinical and clinical evidence supports the view that oncolytic cell death also has immunostimulatory properties. After tumor cells are infected, oncolytic viruses activate pathogen recognition receptors, including toll-like receptors and cytoplasmic receptors, which function as sensors for viral DNA and RNA. These receptors act through several signaling pathways in a process that culminates in the activation of transcription factors, resulting in both the expression of pro-inflammatory cytokines and interferon types IN3 and the release of damage-associated molecular pattern molecules such as high mobility group BOX1, HMGB1, calreticulin, and heat shock proteins, which are recognized by the immune system as danger signals. Overall, these processes promote inflammation and induce innate and adaptive immune responses. Glago-Preslerea et al. Report the results of a Phase 1 study of the conditionally replicating oncolytic adenovirus DNX 2401 in 12 children and adolescents with diffuse intrinsic pontine glioma, an incurable, high-grade glioma that is frequently driven by histone H3 mutations and is associated with a short survival of 8 to 12 months. After a biopsy procedure, the virus was slowly infused into the tumor through a specially designed dual-channel cannula. Successful delivery of the virus into the paunch was confirmed with magnetic resonance imaging after gadolinium administration through a different lumen of the same cannula. Postoperatively, patients received standard of care radiation therapy. The study showed that the intratumoral administration of an oncolytic virus for brainstem gliomas is both feasible and safe. An encouraging median overall survival of 17.8 months was observed. Immunophenotyping of tumor samples that were obtained before administration of the virus showed scarce CD8 and CD4 T-cell infiltration, with myeloid cells being the most abundant immune population, findings that are consistent with glioma-induced immunosuppression. Tumor samples at recurrence were available in one patient, and the features were consistent with remodeling of the tumor microenvironment, probably as a result of virotherapy, with a reduction in the number of myeloid and regulatory T cells and an increase in CD8+ and CD4+ T cell infiltrates. Single-cell RNA sequencing performed at the same time point showed upregulation of pathways in tumor-infiltrating macrophages associated with viral processes, and enhanced immune response, including overexpression of pro-inflammatory cytokines, such as CCL4 and CCL3. No assessment of the oncolytic effect or viral replication in this patient was reported. However, post-treatment samples of tumor tissue were not available in the other patients, which highlights the practical difficulties in obtaining such samples for research purposes, especially from eloquent brain locations, or the brainstem, because of possible neurologic complications resulting from repeat biopsies. All other early-phase trials have shown evidence of biologic activity from their respective viruses, generating a glimmer of hope for patients and their families afflicted by these diseases. We know, however, that the path from demonstration of biologic activity in early trials to final approval of a new agent, which makes a treatment available to patients, can be long and convoluted. Viral entry in tumor cells, which is determined by viral receptor expression on the target tumor, is necessary, but in itself not adequate for viral replication in malignant cells, if they are not permissive. Permissiveness of gliomas to viral replication and oncolytic cell death can be determined by the expression of interferon-stimulated genes, as shown for other oncolytic platforms, such as measles virus. The questions remain as to what degree of viral replication is necessary to produce a sufficient immunostimulatory effect, and how pre-existing antiviral immune response may influence this effect. Expanded testing in Phase 2 trials of these three and other oncolytic viral platforms used in the treatment of brain tumors is planned or ongoing. These studies provide important opportunities for correlative analyses that can help us understand how to enrich future trials with patients who have the highest likelihood of benefiting from oncolytic immunovirotherapy, and how to match patients with the appropriate virus or viruses for their disease. In addition, the immunostimulatory signals generated by oncolytic cell death and remodeling of the brain tumor microenvironment can create the basis for combination strategies with other immunotherapies. Preclinical data from immunocompetent murine models of glioma have shown synergy of different oncolytic platforms with immune checkpoint inhibitors, a finding that generates hope that viruses can help overcome primary resistance to immune checkpoint inhibition in patients with glioma. Phase 2 trials are ongoing, including a recently completed trial of DNX-2401 with pembrolizumab, and a Phase 3 trial is in the planning stages. Viral engineering could further augment this immunostimulatory effect. Exercise 4.1. Answer the following questions. 1. Why is there a lack of progress in developing effective therapies for patients with glioma? 2. Why are engineered replicating viruses used in cancer treatment? 3. Can you describe the process of activating immunity by oncolytic viruses? 4. What were the results of the first phase of the replicating oncolytic adenovirus DNX-2401 in patients with glioma? What was the procedure like? 5. Is viral entry into tumor cells enough for viral replication in malignant cells? 6. What is the challenge? 7. What important information can the studies provide? Exercise 4.2. Complete the text with the correct verbs forms. Write down your own sentences with the given verbs. To evaluate, to receive, to replicate, to place, to assess, to collect, to conduct, to follow, to determine, to have, to result, to associate. We a single center, dose escalation study of DNX 2401, an oncolytic adenovirus that selectively in tumor cells, in patients with newly diagnosed DIP. The patient's a single virus infusion through a catheter in the cerebellar peduncle, by radiotherapy. The primary objective was the safety and adverse event profile of DNX 2401. The secondary objectives were the effect of DNX 2401 on overall survival and quality of life, the percentage of patients who an objective response, and tumor biopsy and peripheral blood samples for correlative studies of the molecular features of DIPK and antitumor immune responses. Intratumoral infusion of oncolytic virus DNX 2401 by radiotherapy in pediatric patients with DIPK changes in T-cell activity and a reduction in or stabilization of tumor size in some patients, but with adverse events. Exercise 4.3. Carefully examine the provided graph and interpret the data presented. Analyze the trends, patterns, and relationships within the graph, and write a concise summary that highlights the key findings and insights. Exercise 4.4. Craft a paragraph evaluating the advancements in cancer chemotherapy, such as the development of immunotherapies. Discuss their mechanisms of action, indications, and potential benefits in improving survival rates and quality of life in cancer patients. Text 6. Read the following text and discuss the management of this specific type of cancer. Paraphrase the author's ideas and arguments. Philadelphia chromosome-positive acute lymphoblastic leukemia. The Philadelphia chromosome, PH, was the first cytogenetic abnormality associated with a human cancer, chronic myeloid leukemia, CML. The rearrangement between chromosome 9 and chromosome 22, a hallmark of the disease, contains the BCR-ABL1 fusion gene, which encodes for a constitutively activated tyrosine kinase signaling protein that sustains the leukemia. In the late 1990s, the first tyrosine kinase inhibitor, TKI, imatinib, was developed, which changed the natural history of CML. Before TKIs were available, patients with CML had a median overall survival of about 3.5 years. With TKIs, patients have a life expectancy similar to that of the general population, without chemotherapy and allogeneic stem cell transplantation. The PH chromosome can also be found in patients with acute lymphoblastic leukemia, or. Although rare in children, this entity, PH-positive or, represents the most common genetic subgroup in all in adults, with an overall incidence of 20 to 25%. The incidence increases with age and accounts for more than 50% of cases of all in patients who are older than 50 years of age. For decades, PH-positive all was considered the leukemia with the worst outcome, in both children and adults, because of the poor response to conventional multi-agent chemotherapy. Allogeneic stem cell transplantation was the only chance for a cure, which was achievable in only a minority of patients, because of older age and a poor response to conventional treatment. The scenario changed when the use of TKIs was extended from CML to PH-positive all. In this review, we discuss how TKIs have improved the outcome of PH-positive all and how we foresee management of the disease in adults in the near future. In particular, we consider the current role of conventional chemotherapy and allogeneic transplantation, with a focus on the close interaction between clinic and laboratory that is necessary for good management of PH-positive all in adults, including the elderly. TKIs in the frontline management of PH-positive all. Before the introduction of TKIs, the response to systemic chemotherapy was limited, and the long-term survival rate for adults with PH-positive all was low, in the range of 10 to 20%, particularly for the many patients who could not undergo allogeneic transplantation. When TKIs were first used, they were added to chemotherapy regimens. The rates of hematologic remission and survival increased, but the combination was associated with notable toxic effects and deaths during induction. The experience was similar in the LAL 0904 study conducted by Gamema, in which imatinib was initially added to the chemotherapy backbone, with imatinib followed by chemotherapy. These findings prompted the design of clinical trials in which TKIs were administered with reduced-intensity chemotherapy, an approach that led to equally satisfactory clinical results with fewer side effects. Since 2004, in all Gamema multicenter frontline trials in Italy, a TKI first, second, or third generation has been used in induction, plus glucocorticoids and central nervous system prophylaxis, without the addition of systemic chemotherapy. This change in practice has required identification of BCR-ABL1 within 1 week after diagnosis, which is feasible in clinical trials with centralized biologic testing. These studies showed that induction therapy, with a TKI alone, plus glucocorticoids and central nervous system prophylaxis, was associated with a complete hematologic remission in 94 to 100% of all adults with Ph-positive ALL, with virtually no deaths during induction. Moreover, many of these studies did not impose an upper age limit for eligibility. The open question was how best to manage the post-induction phase. Most patients received systemic chemotherapy, with or without allogeneic transplantation. Over the years, monitoring of measurable residual disease, MRD previously known as minimal residual disease, has emerged as a key element in the management of ALL, including Ph-positive ALL, for a more precise definition of the depth of the response to treatment. It is well recognized that to eradicate the disease and to cure patients with ALL, a sustained MRD negative status for bone marrow must be the primary endpoint of treatment. MRD can be monitored by means of flow cytometry, but most multicenter groups use a real-time quantitative polymerase chain reaction (RQ-PCR) assay because of the specific BCR-ABL1 fusion marker in Ph-positive ALL. Patients with no MRD fare better. A negative status before transplantation has a good effect on the outcome. Text 7. Read the text and generate a set of conceptual questions related to the main idea discussed. Improving the results obtained with induction with TKIs. TKIs have greatly improved induction treatment, and more potent TKIs than imatinib, dasatinib, and ponatinib are currently being tested in the randomized Phase 3 study, Falcon. In using TKIs, a number of considerations should be taken into account. First, most patients with Ph-positive ALL are elderly, and many are unfit for multi-agent chemotherapy and transplantation. Second, the depth of response to frontline therapy needs to be increased further to reduce the risk of relapse. Third, MRD can be monitored more precisely with molecular techniques. Fourth, immunotherapy is witnessing a new era in the management of cancer, including hematologic cancers, and different monoclonal antibodies are active in B-lineage ALL. Fifth, BCR-ABL1 activity is critical for the immunogenicity of CML cells. Finally, in patients with CML, the host immune system can be boosted through interferon alpha and TKI treatment, an approach that may also extend to Ph-positive ALL. In this context, the bispecific monoclonal antibody blinatumomab has gained attention. Refinement of the techniques used to produce monoclonal antibodies has led to the development of antibodies that target two antigens. Blinatumomab targets CD19, an antigen present in virtually all B-lineage ALL cases, and CD3, which is present on all T lymphocytes. Blinatumomab binds to B-lineage ALL cells, and the antileukemic effect is exerted through the immune system by activating host T cells. This is important because many effector T cells are present, particularly in the context of persistent or recurrent MRD, making blinatumomab a very attractive prospect for improving the response to TKIs in Ph-positive ALL, with or without chemotherapy. This was the rationale behind the design of a Phase 2 study that evaluated frontline treatment of Ph-positive ALL in adults, with no upper age limit. It was a trial of chemotherapy-free induction and consolidation treatment based on the use of the second-generation TKI dasatinib plus glucocorticoids, followed by at least 2 cycles of blinatumomab and additional dasatinib. At the end of the induction phase, 98% of patients had a hematologic remission, and 29% had a molecular response, a complete molecular response, or a response with non-quantifiable disease. The rate of molecular response, the primary endpoint of the study, increased to 60% after 2 cycles of blinatumomab. The rate increased further after additional cycles of blinatumomab. The overall and disease-free survival rates were 95% and 88%, respectively, at 18 months. The presence of additional genetic abnormalities at diagnosis, IKADF1 plus IE, IKADF1 deletion plus additional genetic aberrations, was a negative prognostic factor. Most patients who received allografts had MRD. The positive outcome of the protocol has been confirmed with estimated disease-free and overall survival rates of 71% and 80%, respectively, at 3 years. Patients with no evidence of MRD still remain free from events. In patients who underwent allogeneic transplantation, transplant-related mortality was low. The host immune status was investigated after different cycles of blinatumomab. A progressive increase in CD3 and CD8 T cells, natural killer cells, and natural killer T cells was documented, pointing to the possible role of an activated immune compartment in controlling the disease in the absence of chemotherapy. These results are the basis for a Phase 2 randomized study of total therapy for Ph-positive all in adults. The experimental treatment consists of ponatinib followed by blinatumomab. Ponatinib is a third-generation TKI that is effective against the T315I-ABL1 mutation, which confers resistance to first- and second-generation TKIs. The control treatment is the combination of imatinib, the only TKI approved worldwide for the frontline treatment of Ph-positive all, and chemotherapy. Randomized assignments to the experimental and control groups are made in a 2-to-1 ratio, and a crossover is planned for patients in the control group who have a poor treatment response. This study will assess whether systemic multi-agent chemotherapy can be omitted from induction consolidation treatment, and whether a proportion of cases can be managed without systemic chemotherapy and allogeneic transplantation. Among patients without additional unfavorable genetic abnormalities, e.g., IKADF1+, at diagnosis, those who have a deep and sustained molecular response, and no evidence of ABL1 mutations on MRD-positive cells during induction consolidation therapy will not undergo chemotherapy and transplantation, but will undergo only close monitoring for MRD. The MD Anderson Cancer Center is investigating the combination of ponatinib and blinatumomab administered simultaneously as frontline therapy. At a median follow-up of 9 months, the results are promising, with overall and event-free survival rates of 95%. Text 8. Read the text and highlight the strengths and limitations of this class of drugs. Vinca alkaloids and related drugs. This is a group of drugs that are derived from plants. Vinca alkaloids are extracted from the periwinkle plant, Vinca rosea, although newer ones are semisynthetic. They bind to tubulin and prevent its polymerization into microtubules. Microtubules form the spindle during mitosis, so Vinca alkaloids halt mitosis at a certain stage. Examples of Vinca alkaloids are vinblastine, vincristine and vindicine. These drugs are used to treat leukemia, lymphoma, testicular cancer and lung cancer. Adverse reactions of Vinca alkaloids are relatively mild. Some are due to the inhibition of other functions of microtubules. Thus migration of white blood cells and axonal transport in neurons are inhibited, leading increased susceptibility to infection and neurotoxicity respectively. Taxanes are a group of drugs extracted from yew bark. The mode of action of taxanes is to promote microtubule formation and inhibit their breakdown, so preventing completion of mitosis. The two taxanes currently in use are paclitaxel, which is used in the treatment of ovarian cancer and metastatic breast cancer, and docetaxel, which is used to treat metastatic breast cancer, small cell lung cancer, and prostate cancer. Adverse effects of paclitaxel and docetaxel are similar, being hypersensitivity reactions, bone marrow suppression, peripheral neuropathy, hair loss and cardiac arrhythmias. Podophyllitoxin is extracted from the mandrake plant, Podophyllum punctatum. A derivative of this chemical, etoposide, is used in small cell lung cancer, lymphoma and testicular cancer. The mode of action of etoposide is not completely known, but it may be due to an inhibitory effect on topoisomerase similar to that of doxorubicin. Adverse effects of etoposide are nausea and vomiting, hair loss and bone marrow suppression. Hormones are used specifically in cancers that are hormone-dependent. Growth of such tumors can be suppressed by hormones with the opposite action, by hormone antagonists, or by inhibition of hormone secretion. Hormonal treatment plays an important role in the management of cancers of the breast, prostate and endometrium. Glucocorticosteroids are used in leukemia because they inhibit proliferation of lymphocytes, and in palliative care of other cancers, because they can stimulate appetite and produce a sense of well-being. Radioactive iodine, although not a hormone itself, is taken up by the thyroid gland and incorporated into thyroid hormones. During this process, it emits radiation that causes destruction of the thyroid gland. It is used specifically to treat thyroid tumors. Radioactive iodine is also used to treat thyrotoxicosis. Miscellaneous drugs. These anti-cancer drugs do not fit into the other groups. Most are cytotoxic in some way, and cause the usual side effects. They are used for specific indications. Some examples are given below. Procarbazine inhibits RNA and DNA synthesis and interferes with mitosis. It is a drug that interacts with alcohol and generally increases the effects of central nervous system depressants, and can produce hypertension. Hydroxyurea inhibits ribonucleotide reductase, which is necessary for the conversion of ribonucleotides into deoxyribonucleotides. Crisantaspase breaks down asparagine, which some tumor cells cannot synthesize. Normal cells can synthesize asparagine, therefore the drug is selective for certain tumors. Biological response modifiers are drugs that enhance the patient's natural response to cancer. They are used only in specific types of cancer, usually if more conventional chemotherapy has failed. Interferons are produced by many cells of the immune system, and some, interferon, have anti-tumor effects. Interleukin-2 regulates the proliferation of tumor-killing T lymphocytes and natural killer cells. Tretinoin is the acid form of vitamin A. It induces differentiation in leukemic cells. Monoclonal antibodies, rituximab and alemtuzumab, have been developed recently which cause lysis of B lymphocytes. These drugs are intended to be used in particular types of leukemia when other forms of treatment have failed to produce a long-lasting remission. The most serious adverse reaction with these drugs is the so-called cytokine release syndrome. This includes fever and chills, nausea and vomiting, and allergic reactions such as rashes, itching, angioedema, bronchospasm, and difficulty breathing. Fatalities have occurred, and these drugs are still being monitored by the Medicines and Healthcare Products Regulatory Agency, MHRA. A monoclonal antibody against human epidermal growth factor receptors, HER2, has been developed for use in metastatic breast cancer. This drug is trastuzumab, Herceptin, and is also being monitored by the MHRA. New approaches to treatment. Drugs that target known oncogenes are under development. These drugs are known as antisense oligonucleotides, ON, which are small synthetic pieces of DNA that are complementary to a segment of mRNA. A hybrid of ON DNA and mRNA forms, which prevents translation of the mRNA. This means that the effect of the original oncogene is blocked. Cancer cells produce enzymes that can break down the extracellular matrix between normal cells and allow cancer cells to invade and spread in normal tissue. New drugs are being developed that inhibit these enzymes. In order for tumors to grow, they need to develop a blood supply. Drugs are being developed that inhibit angiogenesis, which is the growth of new blood vessels. A monoclonal antibody, bevacizumab, that inhibits vascular endothelial growth factor already exists for use in metastatic colorectal cancer. There are serious side effects, such as gastrointestinal perforation and impaired wound healing, and its use is being monitored by the MHRA. Other areas of research include the development of drugs that block the capacity of oncogenes to turn cells malignant, antagonists of growth factors, inhibitors of cell cycle control factors, and gene therapy to restore tumor suppressor gene function.